everyone. This is Priya from MedWorld Expo, an unified digital healthcare platform which is connecting manufacturers, distributors, healthcare services, and healthcare experts like Shefali worldwide. Dr. Shefali Garg, a cheerful, energetic, and passionate endodontist from Chandigarh. She completed her graduation from the prestigious Punjab University and went on to pursue her master's in conservative dentistry and endodontics from Himachal Pradesh, where she emerged as the gold medalist of her branch. Dr. Shifali believes in conserving every tooth conservatively and approaches each case with utmost diligence. She has developed expertise in single visit endodontic treatments and always strives to plan treatment in the most suitable and patient friendly manner. Beyond her clinical practice, Dr. Shifali is an enthusiastic teacher and content creator. Through her Instagram platform, Dental Grail, she simplifies dentistry for students by sharing practical notes, checklists, articles, and unsponsored materials suggestions. Her content is designed to make dental education easy to understand, approachable, and effective. She is truly passionate about imparting knowledge and aims to help students grasp concepts without unnecessary complications, inspiring them to strengthen their foundations in dentistry. This is a great achievement till now, what you have done, your journey in the medical industry. Let's give a warm welcome to Dr. Shifali Garg. Thank you, Shifali, for
Thank
giving this session to our audience. Can you please start?
yeah, thank you so much for such a nice introduction. So, as already the introduction has been done, I don't need to do anything else. So, we'll just start into the presentation and the topic for today.
Exactly.
I hope the presentation is visible to all.
Yes.
Yeah, okay. So to begin with, I belong to Chandigarh, which is the city beautiful. And as we've already mentioned about the BDS and MDS that I have done, and about my Instagram page, which I've created since the past 8 months and built to a community of about 1,800 students. So, digging into the topic for today, which is how to look into the tooth, that is decoding access opening from centrals to molars. Now, we all know that access opening is the first step of any endodontic treatment, which is actually being done on the patient. Before the access opening, whether it's diagnosis or it is treatment planning, nothing is being done on the patient. So, access opening forms the first step of our treatment, which we are performing on the patient and leads us to the final success of the treatment. So to read the theoretical part of the access opening, you can follow any of this book, Grossman being the basic, which most of us have read during our undergraduate journey, and others being which we read during the PG. Now, if suppose someone of you is a general dentist and you also want to read about endodontic treatment, you can choose as Cohen, The Pathways of Pulp as your basic book to read about whole of endo. If you want some clinical tips, you can go on to Wien. Bean is like the person has written the book in first author. He tells about his own experiences and how he has performed endodontics over the years. So after the references, I shall also like to tell you that I'll not be covering the basic topics like laws of access opening and the shapes of access cavity in detail as we do in college, because that is only theoretical knowledge which can be read from any book like Grossman, Cohen, or even if you read Nisha Garg. You can get the information about the basic details from any of the book you have. What I'll be showing is how to do the access opening clinically and how to access a canal, or what location exactly should you see a canal for. So to introduce the topic, access opening is the first step of the endodontic treatment, and it is important how we perform the opening so that we create a straight line access towards the root canal. So access opening forms the first and the most important phase in the root canal treatment, and a properly prepared access cavity creates a smooth straight line path to the canal system and finally to the apex or any curvature which is present. This is just a theoretical definition which you need, and other than that, Now, first thing which we'll discuss is the key steps in accessing the root canal system. Now, after you've done the diagnosis, which includes the clinical examination, radiographic examination, the pulp sensibility test like heat test or the cold test or electric pulp, whatever test you do, after you've done the diagnosis and reached to the age that treatment is RCT, then we begin our procedure. So the first step is always local anesthesia administration followed by rubber dam placement. Now, it is very good if you use a rubber dam, but even if you're not using, it's not feasible or your practice doesn't allow or you don't have time or whatever reason may it be, it's okay. You can use you can perform the procedure without rubber dam placement and do the main procedures like the working length administration and obturation under under the cotton isolation or any sort of isolation. Now, starting with the access cavity, the first step is obviously caries excavation. Caries excavation means caries hatana. From the tooth, the complete caries removal has to be done. You cannot do that. There is a molar and you do the access opening, but distal part of the molar contains caries. You cannot do this. Before you move towards the pulp chamber, caries must be removed completely. The most easiest burr to use are the round burrs. These are easily available in any clinical practice. Now, if you want to up your practice, you can use this burr. It consists of a taper burr along with a round burr. So two burrs in one, and all the edges are cutting. This is called as an endo access burr. So this round burr will go on digging into the tooth, and the walls of the burr will cause the cavity to flare up on the sides. So this does dual purpose. After the caries excavation, you have to remove the dentine up to the roof of the pulp chamber. Now, what does this mean? Like, as you can see in this diagram, if this is the roof of the pulp chamber, this roof completely has to be removed. If you do not remove this roof, the pulp over here will stay as a remnant and it can later on cause infection. So, if you are going into the tooth chamber, this whole roof has to be removed. So complete de-roofing of the pulp chamber has to be completed. And after that, you move on to the next step. The next step would be, now, if suppose the de-roofing is not completed, what will happen? Like, as you can see here, ideally the access cavity should be like this. From here, it should flare out, but a dentinal overhang is present over here. So the pulp remnant will be present in this tip of the pulp chamber. So if de-roofing is not done properly, it leads to poor accessibility of the orifices because all orifices will not be accessible to you. It will cause the remnant pulp to stay in the tooth. You can also have some missed canals. There can be poor disinfection and there can be dentinal overhangs. So all of this will cause a difficulty in creating straight line access. Now, what does this image show? This is the common mouse hole effect which we talk about in molars when the wall of the molar and the floor of the chamber contain the orifice. Ideally, the wall should be drilled more towards the outside so that the orifice is completely in the center with no contact with the wall. Now, after the de-roofing has been done, you have to visualize the root canal orifices, as many as you think are present in that respective tooth. Now, next, you extirpate the pulp using a barbed broach or an edge file. You can use a 20 number or a 25 number edge file and easily remove the pulp which is present in the canal. Now, if excessive bleeding is present, you must irrigate the tooth with sodium hypochlorite without any pressure, and ideally you should use a rubber dam. If not, place cotton rolls on the sides and suction on top of the tooth so that the hypo doesn't go into the patient's mouth. Next, you have to remove the dentinal overhangs and the lingual shoulder. Now, what's a dentinal overhang and a lingual shoulder? Like, this is a maxillary incisor, this is lingual, this is buccal. So this area forms the lingual shoulder. And this part of dentine which you see is the dentinal overhang because it is hanging over the pulp chamber. So ideally, the cavity should be from here and it should be widened from here as well, because right now we can see that the file is stressed at this point, and eventually if you keep using this file in this location, it will cause separation over here and ledge over here. So ideally the cavity should be divergent and flared in order to provide a straight line access like this. There should be complete divergence of the cavity, and then the file will not hinder over here and no ledge will be formed in the apical area. Now, common difficulties which you face in access cavity preparation. First of all, is when you're going into the cavity, you usually feel a drop. What is a drop? That when you're moving from hard tissues, enamel and dentine into the pulp, the refractive index and the density of the tissue changes, due to which you feel a sudden hollow structure into which you've entered. This mostly happens when the tooth is vital. Now, if the tooth is not vital, it is non-vital, and over time the pulp has formed secondary dentine or tertiary dentine, the pulp gets blocked, the pulp chamber gets blocked, and you do not feel a drop. So, in that case, how to find the orifice? This is number one difficulty. Number two is poor visibility. Suppose there is too much bleeding, or the tooth is like an upper second molar, and you cannot visualize the distobuccal canal or the palatal canal. That is the second difficulty. Third is creation of a perforation. Perforation is when you have gone off the root and you have drilled outside the tooth into the periodontal ligament. Fourth is when you are not able to locate all the canals. Like suppose there is a maxillary molar, it should have three canals. You can visualize three roots on the radiograph, but you are not able to find three canals clinically. So these are the common difficulties which we face. Now, I am not going to leave you with the difficulties. Let's talk about the solutions also. So for a calcified pulp chamber, you can use your basic ultrasonic scaler which you have on your chair. Place the pointed tip of the scaler and try to disengage the calcification. Like if you have opened a tooth and you know the suggested position of the canal, so you place your ultrasonic scaler tip on that position and try to remove the dentine shelf over that. After you remove, you will see a small ditch where you can engage any small number file like number 8, 10, or 15 and negotiate the canal. Now, if you are facing poor visibility, suppose there is a very hyperemic pulp present in the tooth, so you irrigate with hypochlorite because hypochlorite will react with the pulp and necrose the tissue. The necrosed tissue will not bleed, and you will be very easily able to remove the pulp from with the rotary files or with an H file. Then you can also use an LN burr, which is a long burr. It has a long shank. So you get to visualize the tooth and the air rotor doesn't block your vision. Like if this is the tooth and you place the burr, you have all the available space on the sides to visualize the tooth chamber. Next, you can also use the correct size of the hair rotor. Suppose you are working on a 2/8 or a 4/8 and the patient is not able to open the mouth. So you can use a small or a nano head hair rotor. And also you should always work in indirect vision for maxillary molars, because if you try to bend your neck and try to visualize the molar, it will not help you. You will not be able to see anything, and also additionally you will harm your neck and your ergonomics. So ideally work in indirect vision always. If suppose there is a perforation, then to avoid the perforation, first of all, you should visualize the axis of the tooth, not just the crown, because in teeth like mandibular premolars, the crown is inclined, but the tooth is straight. So you must know the angulation in which the tooth is usually present and then go parallel to that. And if suppose a perforation has occurred and you have detected that it is a perforation, the first step has to be sealing the perforation without any doubt. There should not be any cleaning or shaping or obturation. Perforation repair is the first step once the perforation has occurred. Now, moving on, if you are not able to locate all the canals, like in molars, there are four canals. Suppose you know a maxillary molar has, you can see there is one mesiobuccal root, one distobuccal, and one palatal. So three canals minimum should be present. If suppose you're not able to, there are 8 to 10 methods which are written in all the theoretical books and some which are shown clinically to be useful. The first is there should be complete chamber deroofing, as we've read before. If the chamber is not de-roofed, dentine is present on the chamber, these all canals will be hidden. Second is to use sharp explorers like DG16. Like in this image, you can see a DG16 can be used to remove the shelf of dentine overlying the orifices. Third are micro openers. These are from the brand Dentsply. You can use them if you want, but a sharp explorer works just fine and it is much cheaper. Then you can use dye, like you can use a micro applicator tip to place 1 to 2 drops of dye in the canal, which will react with the tissue of the pulp, and wherever the reaction occurs, you know the canal is present over there. Next is the champagne bubble test. Now, as the name suggests, there is going to be a bubbling action caused by which irrigant. So, hypochlorite is used. You place it in the chamber, and hypochlorite reacts with the tissue. Wherever the tissue will be present, it will cause bubbling action. And you can pass your file into that orifice to negotiate the canal. Next is the red line test or the bleeding point. Now author suggests that whenever there is an extra canal, there will be bleeding present between the two canals. So as in this image, this is mesiobuccal orifice and a red colored line is seen. It means that here an extra canal might be present. So an MB2 will be present over here. Next is the white line test. Now, what is white line test? That when you use burr or ultrasonics to trough the path over here, the debris get lodged in the pack, in the tract. If the debris is lodged, it means there is a tract. And if a tract is there, it means two ends are present. One is first canal, and the second, there will be another canal on this. Next, you must look for dentinal map endpoints. So this is the tooth inside the pulp chamber is seen. Now this path which you see is called as dentinal map, a map which occurs in the dentine. So it clearly shows that there are four endpoints of the map, means there will be four canals. And last is troughing. Troughing is done using burr, where you create small digs into the pulp chamber without perforating, hoping to find the canal. So these are some methods which you can use to locate all the canals in a tooth where you're not able to find directly. Now moving on to tooth wise, we'll not discuss about each tooth in a lot of detail in theoretical terms, but more in clinical terms. Now coming to incisors, we have four incisors: maxillary central lateral and mandibular central lateral with their counterparts, which makes it to the eight total. So we need to study about the shapes of incisors for four incisors. Now coming to maxillary incisors, the central and the lateral. Central incisor has a bigger surface area than the lateral, and the lateral is a bit more rounded. So the access cavity of the central will be triangular as its own shape, but that of a lateral will be more rounded because it has a smaller surface area. Also, when you are starting the access opening, you must go 90 degrees into the tooth and then become parallel to the long axis. That way, you will avoid deviating your path. Now, if you have to look about the variations in these, maxillary central doesn't usually have any variation. It contains one canal, but the one canal can be open in some immature teeth. For maxillary lateral, usually there is a distal curvature in the root, so the access opening stays the same. Now, access opening can be tricky in two cases. First is palatogingival groove, and second is a dens invaginatus. Now, what is a dens invaginatus? When the cingulum of the tooth has sunken into the chamber. So there is like a dip. So you need to drill through that part, and sometimes one to two canals can be present under the dents. Now, next is palatogingival groove. As you can see in the first figure over here, the this line, this line is the palatogingival groove. So sometimes this palatogingival groove, it moves towards the apex and itself is a different canal. In these cases, you need to disinfect this groove also. And when this, sometimes this groove is not accessible coronally, so surgical exposure might also be required to gain access to this groove and seal this groove permanently with materials like MTA. And it is very common to cause perforation in maxillary incisors because we tend to drill perpendicular to the tooth and go through and through. But ideally, you should approach from here, go 90 degree, stop, go with the round burr, stop, shift to a taper fissure or a taper round burr, and then go parallel. This way, you'll save whole of the buccal part of the tooth, which provides the strength and the aesthetics to the tooth. Next, we move to mandibular incisors. Mandibular incisors are a difficult tooth from the point that they are very small. The burr size which you use matters a lot because the tooth surface to drill is very, very small. If suppose you are using this tooth and you are using a round burr which is large, you are going to ruin whole of the cingulum and the edges of the tooth, which will cause the strength of the tooth to be lost, and finally the tooth will not last long in the oral cavity. So ideally, you should use a small round burr to begin with the access opening and then maybe shift to a straight burr, which is thin in diameter to gain access to the orifices. So now the most important thing for incisors of the mandible is that this portion is called as the lingual shoulder, which lies on the lingual and contains the bulk of the cingulum. Now, mostly when you access the tooth, this is the canal where you easily put in the file, which is the buccal canal. But if you have not removed this lingual shoulder, sometimes a hidden lingual canal is present over here. As seen in these radiographs, two canals were there. So you should remove this lingual shoulder and try to look for another canal, because this canal will not be easily accessed like the buccal canal. So you must extend into the cingulum gingivally and also create an ovoid cavity so as to find this extra canal. As seen in this radiograph, all these three teeth had two canals. This one also had two canals, but it got overlapped. Now, moving on to canines, canine forms the cornerstone of the dentition. Therefore, the bulk of the canine should be maintained. You cannot just drill blindly into the canine and dig wherever you want to. Mostly, the maxillary canine contains one canal, but it can contain two also. Mandibular canines have commonly been found to give two canals in presence, but mostly both of them contain one canal. The access cavity is quite similar for both, which is ovoid in shape, but mandibular canine has a smaller crown, so the access cavity is a bit smaller. Otherwise, mostly it is same. The problem you face in canine is that the canal is very bulky. So if suppose you put a file in the canal, it is very loose in the coronal third. So the disinfection of coronal third is very difficult and important because it is ovoid in shape. And since it is ovoid, you need to do circumferential filing. Circumferential filing means पूरी circumference पे you have to rub your file around the circumference so as to remove the pulp and the necrotic tissue. Coming on to maxillary canine, as you can see in the image, the access cavity must be flared on the top so as to access the complete ovoid cross section of the canal. If suppose the access would be thin over here, so this tissue and this tissue will stay unaccessed and you will not be able to clean it, and that will eventually lead to your failure. So buccolingually, the dimension is wide. And also when you're accessing like maxillary canine, it is difficult to visualize sometimes and you tend to dig your burr like this or in this direction. This can cause a mesial or a distal perforation. So always check your angulation and go parallel to the long axis so as to avoid perforation, because perforation reduces the success of tooth by more than 50%. If there is a perforation, means there's a leak which you have created and you have to seal it. So that will not be a natural, that will be a man-made error which will have a man-made seal. So that seal will not be 100% good. Next, when you move to mandibular canine, it is similar to maxillary as I've mentioned before, but mostly it can have two roots and two canals. So you must take angled radiographs to visualize if an extra root is present. Also, for the mandibular teeth, there is a lingual inclination of all the teeth. So here you might have to go up to the incisal edge to gain a straight line access. Like in this image, if you put the file like this, the file will bump over here. So ideally, you can go up a bit, and here, if you insert the file, it will go straight. So you'll have to go to the incisal part of the tooth till here and to the cingulum part at the cervical portion. Moving on to the premolars, premolars form the toughest part of the oral cavity because of the n number of variations which are possible, be it maxillary or mandibular. Nowadays, maxillary premolars are being researched a lot, and it is not that they have one to two canals. They can have up to three to four canals with two to three roots also. So premolars are the most varied variety of teeth in the oral cavity. Starting with the maxillary first premolar, it is the difficulty in maxillary first premolar is because of its tooth structure, which is that if suppose this is the tooth and this is the mesial part, the mesial part has a concavity. Concavity means like a pit. So when you access the tooth, if suppose you go wrong with the angulation, it is very easy to cause a mesial perforation. So you must avoid that. You should start in the central fossa and go buccal, go lingual, and stop. That's it. You just have to access your canals and see if you found them. Then widen the cavity as much as you need. You will not have to change your angulation, and the perforation incidence will decrease a lot. So mesodistal cutting is not required. Buccolingual cutting is what is needed. Also, if three canals are present, mostly two buccal and one palatal is present, wherein the premolar mimics a molar. So you will have one mesiobuccal, one distobuccal, and one palatal canal. Maxillary second premolar resembles the maxillary first premolar a lot in its shape, but maximum times the second premolar contains one root with one canal, making it an easier case than the maxillary first premolar. So usually it is a rounded canal present in the center of the tooth, which is a very conservative access opening. You don't need to extend mesial, distal, or buccolingual. And also it is very easy to disinfect because there is no isthmus or joining between the canal. Like if suppose two canals are present, there will be an isthmus between them. Like in this image you can see, if this tooth has a broader coronal third, it will become difficult to clean this part. As seen in this image, this is the isthmus zone. Cleaning this is difficult, and cleaning one single canal will be easier. So the success chances of maxillary second premolar increase because it mostly contains just one canal. Moving on to the next category of tooth will be mandibular first premolar, which is also known as the enigma of endodontists. Now, why so? Because as I talked in the starting of premolars, that they contain the maximum number of variations. So, mandibular first premolar is one such tooth which can have too many variations, varying from the root to the number of canals. So, as you can see over here, firstly, the anatomy on the occlusal surface is very different. You don't have a wide occlusal surface to dig into as in maxillary premolar. There is a very small area where you have to access. You access mostly in the center on the occlusal surface, but you cannot drill more into the lingual because the lingual cusp is very less developed for mandibular premolars. So you have to stay mostly on the buccal. But now, if you stay mostly on the buccal, it can cause a perforation on the buccal if you go on going straight. So you have to create an angle, but also stay in the canal. You have to create an angle only till this part, and then you have to become straight. You cannot go on at this angle only, it will cause perforation. Okay, so and another common variation for mandibular first premolar is that even if it has one root, it can have one main canal in the coronal part which splits into two. So that forms a very difficult case because usually the splitting occurs at a very sharp angle, and one of the canals of the two is difficult to clean. The first canal which you access is usually easier because a path has been formed. So you should analyze it beforehand if the tooth has two canals, and then only you should start the preparation. Coming on to mandibular second premolar, it is easier than mandibular first premolar because mostly it contains one canal and one root, but variations are possible in this tooth also. Now, as I did a case, as you can see here, this premolar was a second premolar in a 16-year-old boy. He was going for ortho and they wanted this tooth to be saved. So the tooth was already tilted and completely decayed, but this tooth had two roots, as you can see, and one root had one canal, but one root had two canals. So these two canals were mesiobuccal and distobuccal, and this one was lingual canal. So there were three canals, and the roots were two in number. So variations are possible in any tooth. It is not that this tooth cannot have this anatomy. Any tooth can have any anatomy. You must know what all anatomies are possible. Then only you will be able to look for that in any tooth. Now moving on to molars. Molars form the biting part of our oral cavity, and hence they need to be saved at all costs. Conserving teeth with RCT or with restoration is the sole aim, because losing a tooth which is 80% involved in your diet, in your food, is not affordable. You must maintain these teeth in the oral cavity and not run behind treatments like implants, extractions, etc. Saving a tooth, even if you have to do a fiber post, is always helpful for the patient. One must think always in the patient's favor. Now coming on to maxillary first molar also contains many variations like the mandibular first premolar. So the most common variation which everybody knows and is the talk of every lecture is MB2. But is MB2 so rare? No, it's not. It is almost present in like more than 90% cases. And if you're using magnification, it is present in more than 95% of cases. So MB2 is like, it is always present. It's just that we don't find it. We don't look for it, so we say it's rare, but MB2 is not rare. Four canals in maxillary first molar is the basic, but it can vary from having 1 to 4 roots and 1 to 6 canals, which means three roots, that is MB, DB, and palatal, are always there. but there can always be an extra root in the mesial or the distal. Also, if three roots are present, each can also have two canal each, like two mesiobuccal, two distobuccal, two palatal, and there can also be three mesiobuccal. So the incidence of all these canals is present in maxillary first molar. Now, if you see that the axis cavity is present only in the mesial part of the tooth, and ideally the oblique ridge should not be cut open. The oblique ridge forms the strongest part of the tooth. So the palatal canal is mostly in the center of the palatal surface. Distal canal lies near the distal cusp, but the mesial canal is like from the distal and the palatal, but onto the mesial surface. Now, if you want to locate the mesiobuccal canal, it is very easy that mostly it lies mesial and palatal to the mesiobuccal. So if this is mesiobuccal, mesiobuccal too will lie more mesial and palatal. And also, many students face problem while inserting file into the mesiobuccal canal. Like if you will go 90-degree into the canal, you will never be able to insert the file. So the ideal direction to go into the mesiobuccal is from the distopalatal, and same ways to go into the distobuccal is from the mesiopalatal. So this is the direction of the files. Now, as I've shown these cases, here this case was a retreatment case where I found an MB2. This mesiobuccal and distobuccal was already present. And this was the same case where I found this was the main palatal canal and this was another palatal canal which I found. So this was mesiopalatal and distopalatal. So 5 canals were there in this maxillary first molar. On the other hand, I have also found only 2 canals in a molar. There is only one buccal and one palatal canal. So both are equally big in size, like the size of a palatal canal. The buccal was same. So there were only 2 roots and 2 canals. So there can be many variations which are possible for maxillary first molar. Coming on to maxillary second molar, it usually contains 3 roots and 3 canals, but MB2 is commonly found in second molar also. The one thing which one must know in second molar is that the distobuccal canal is not really present in a triangular form as it is present in first molar. It is likely towards the mesiobuccal and the palatal and is present in a straight line. Like usually you will not be able to find a distobuccal canal over here. Mostly it will be present in a straight line between the mesiobuccal and the palatal, very close by. So this is a very common finding in maxillary second molar because the occlusal table tends to constrict and the roots are present very close by, due to which the orifices are present close by. Also, a common finding in second molar is 2 roots and 2 canals, as we saw in the previous case. Though that was maxillary first molar, this is maxillary second molar. Coming on to third molar, now maxillary third molar or mandibular third molar, both are equally variable. They do not have any fixed anatomy of the root or the canals, but we are always hopeful to have 3 roots and 3 canals in the maxillary third molar also. But C-shaped canals and fused roots and fused canals are also a common finding in maxillary third molar. But the maxillary third molar is not always required to be extracted. In some cases, the patient might not have a second molar, and third molar can serve as a very solid abutment for the bridge if you are planning over 6 and 8 to salvage the 7 edentulous spot. Coming on to the mandibular first molar is a very big tooth and has a good occlusal table, so the access opening usually is easy. But mandibular first molar contains 2 roots with 3 to 4 canals. Now the canals can be 2 also, but they can be 6 also. So 2 roots means there is one mesial root and there is one distal root. Now mesial root usually contains 2 canals, mesiobuccal and mesiolingual. And distal usually contains one canal, which is a long canal, which is distal. But distal can have 2 also. So that will be distobuccal and distolingual. This is normal anatomy, which you must look for in every case. Now, sometimes what happens that mesiobuccal and mesiolingual, they contain a connecting anastomosis, due to which a third canal is present between them, which is the mid-mesial canal, as seen in this image. And similarly, in the distal, there can be a third canal, which is called as the mid-distal canal. As I'll show you in this case, see here 3 canals are present in the mesial. This is my own case. This is a distal orifice, which is only one. This is mesiobuccal, mesiolingual, and this is mid-mesial. So mid-mesial is a common finding. It is more common than mid-distal. Now this was when 2 roots are present and the number of canals can vary. Now, if there is a third root can also be present, and that is known as radix. Radix is the name of the third root which is present in the mandibular first molar. Basic information is this. Now, you usually see two terms, radix entomolaris and radix paramolaris. These are not some very big terms which have some science behind them. It is just that radix entomolaris is the term given to the extra root when the root is present on the distolingual aspect. It means if this is distal, this is mesial, so the root will be present on distolingual. And paramolaris is when the root is present on the mesiobuccal. To learn easily, you can say that BP, as you learn blood pressure, buccal is para. So buccal, mesiobuccal root is paramolaris, and the opposite will be distolingual, which is radix entomolaris. As seen in this radiograph, this is the normal distal root, this is normal mesial root, and this is the accessory root, which is the radix. This is the clinical photograph of the same case. This is mesiobuccal, mesiolingual, distal, main root, and this is the extra canal. Moving on to mandibular second molar. Mandibular second molar is also easier to treat as compared to maxillary, but mostly it can contain 1 to 2 canals with 1 to 2 roots, but also it can contain C-shaped canals. Now, in this case, as we can see, there was one root and only one canal. This the caries was coming till here, so this was like almost a perforation, but it didn't happen. So this was just one canal, as seen in the clinical image also. One canal was present, and obturation was done using vertical compaction because the canal diameter was like 80. So you can not use rotary file in such cases. So the variation possible is one canal in one root, or it can be two canals in two roots, and there can be up to 6 canals as mandibular first molar. A common another anatomy is C-shaped canal. Now, how do you know if what is a C-shaped canal? For C-shaped canal, the when you insert the file into the mesial, it freely moves into the distal. There is no isthmus between them. That is a C-shaped canal. As also mandibular third molar presents commonly with C-shaped canals. To confirm a C-shaped canal, a file placed in the mesial canal moves freely into the distal and indicates a connected mesial distal canal system, which is the C-shaped canal. And the third molar is same as maxillary for third molar, that it contains varied anatomies like fused roots, dilacerated roots, C-shaped canals, one root, two canals, anything can be present. Third molars do not have a fixed anatomy कि ये तो इसमें होगा ही. You can expect anything to come out of these. As seen in this third molar case, there was one main canal, which was the distal, and this was a mesial canal, which fused into the distal canal eventually. So the GP, when I was preparing it, both the canals were patent till the apex. But when I inserted one GP, the second GP went only till here. So second GP could not go till here. Means the exit was one, but the orifices were two. That is 2:1 anatomy was seen in this case. I hope all the anatomies are clear. I know it's too much of like details and facts, but once you practice and once you've done every tooth multiple times, these anatomies get fixed in your brain and you know where to look and what to look for. Now, moving towards the end of the presentation, access, I would like to say that access preparation is like a window. It leads you to a whole new world inside a tooth. If the window is not opened correctly, the view you see can be compromised. So, to know what you see, you must see what you do. Thank you for your patience. And if anybody wants to connect with me for any doubts or anything else, you can contact me on the LinkedIn, Instagram, or this is my Gmail. And I openly help students whosoever interacts with me or asks me about topics for seminars, JC, or any clinical cases. If you want any help, you can contact me anytime. Thank you.
Thank you, Shefali, for the detailed explanation on this topic. They have some questions which they
Yeah.
have kept in the chat box. We
Okay.
can go one by one. There's a question from Rakesh. Good afternoon, doctor. How important is preserving tooth structure during access cavity preparation?
Okay, so taking this question, like as we have moved from the conventional access cavity towards a conservative access cavity, it is important to save the tooth structure because the strength of the tooth structure lies mainly around the CEJ, which is the cemento enamel junction. So if you're around the CEJ, 4 mm coronal and 4 mm cervical to the CEJ, that area should be maintained. The strength should be maintained. So whenever you are doing an access cavity, it should be divergent but in occlusal direction, so that the CEJ is preserved, so that when you do final restoration, the tooth is more and the restoration is less, so that the tooth can bear the forces.
Yeah, there is question from Mr. Venkat. Hello, I am
Then so,
Venkat Sohan. What are the most common challenges faced while performing access opening in anterior versus posterior teeth?
okay, so common challenges in anterior teeth is that um, perforation is very common when you're talking for maxillary anteriors, because usually we do not have a habit of working in indirect vision. So perforation is a very common error in access cavity of anteriors. In posteriors, the challenge can be to look for all the canals, to find all accessory canals, and to cause complete disinfection of the canal system. Those are the most common challenges. Also, in challenges in the posterior, you can face is file separation, and in lower anteriors also you can face file separation.
That's great, Shefali. There's a question from Pranita. How has the concept of conservative access cavity design changed traditional approaches?
Okay, so as we've there has been a study by Clark and Khademi who introduced the traditional access cavity concept. According to them, a conservative access cavity. So according to them, only like a truss cavity or a conservative access cavity was needed. But according to the research, this is not 100% beneficial, because if you're making a conservative access cavity, means you are leaving some part of the pulp on, or the pulp chamber on the side, so that can cause reinfection later on. But if you use system like gentle wave or good irrigation protocols, then you can use a conservative access cavity. You cannot use conservative access cavity with conservative instruments like hand files and basic needle irrigation. You need to up your armamentarium. You need to use activated irrigation or laser irrigation or gentle wave system along with good rotary systems. Only then a conservative access cavity is beneficial.
Okay. Question from RV. In retreatment cases, what special considerations are needed for reaccessing previously treated teeth?
Okay. So in retreatment cases, it means either there will be a crown present or there will be a composite restoration present. So first of all, coronal disassembly is the first step, which includes removing the crown, removing whole of the restoration, and analyzing what tooth structure is left with you. Then you analyze if the retreatment can be carried forward or not. You should never promise the patient success before you have seen the remnant tooth structure. So first of all, remove the crown, remove the restoration, visualize the orifices, remove the GP. Now, when you have removed the GP, sometimes post is present, sometimes fiber post is present. In those cases, retreatment is difficult. So if the radiograph shows that a post is present, you should not go for conventional non-surgical retreatment. Instead of that, you can go for a surgical endodontic procedure.
Okay. This question from Satvika. How can digital dentistry tools, CAD CAM, guided endodontics support precision in access opening?
Definitely, if you have access to CAD CAM and guided endo, that is a great tool, because it creates a guide which can be placed onto the tooth, and it integrates CBCT into the guide. So if CBCT shows that the canal is present at XYZ location, the guide will show you that location in as a circle, and you have to place your drill directly into the circle. So that is 100% result. You don't need to drill anywhere else. There will be no perforation, there will be no missed canal, so it obviously increases the precision many folds.
Okay. This question from Kavya. Could you please share a few real world examples where innovative access strategies saved the tooth?
Mm, sorry.
Did you
Okay.
get the question or
Yeah,
should
yeah,
I
real
repeat?
world examples where innovative access travel strategies saved the tooth. Okay, so if you're using like truss cavity or you're using traditional access cavity, conservative access cavity, it has saved the teeth for cases where like you don't have much time. Suppose you don't have much time, the patient is in pain, or you know that there is no electricity supply, and the like in real world situation what we have faced in the clinic, suppose the electricity is not there, the compressor is not working, so you just create three drills in three canal locations that will relieve the pain of the patient, at least for now. So the truss cavity is useful for this one purpose. Other than that, it is not very effective because the pulp under the truss cavity area is not cleaned. So ideally, you should use conventional cavity preparation, but conservative. You should not overcut the tooth.
Okay, that's all for the day. Shifali, it's great explanation. Till now, I'm listening to so many webinars, but I somehow felt to tell about the feedback about your session. It's very systematic, organized, and clearly explained regarding what you wanted to keep in the presentation, as well regarding the questions. Thank you
Definitely.
so much. Nikhil would like to talk about MedWorld before we close the session.
Yeah, sure.
Okay. Thank you.
Thank you and your answer. So just before we close this, I just wanted to take 2 minutes of my time and show the MedWorld Expo platform which made this webinar successful. So let me share my screen. I hope my screen is visible. Somebody can confirm. Can you see my screen, Shafali ma'am?
Yes.
Yeah. So MedWorld Expo is a global healthcare platform. So here we do manufacturers, distributors, and healthcare network complete. They can do their networking over here. So that is the major reason of MedWorld Expo. As most of the people whoever I have attended this webinar is doctors and medical students and healthcare professionals, right? So in this perspective, let me show you what are the major benefits that they can get through MedWorld Expo platform. So first thing, you will be able to network with manufacturers, distributors, and healthcare service providers, where you can able to browse different kind of hospitals, laboratories, diagnostics, and all the healthcare organizations. That is one first thing. And second thing, you will be able to attend different kind of webinars the way you have attended this webinar. So we have so many upcoming webinars in the next week. So we have more than 4 to 5 webinars. So people who haven't registered for those webinars, please do register. As you can see on screen, we have multiple webinars on different specialities. So even you can apply to all those webinars, which is completely free of cost. And if you wanted to like see the old videos of our MedWorld webinars, just click on the videos, just click on that, you will be able to see recorded webinars. After that, as you can see over here, we have CME programs, which we are going to start soon. It is a credit-based CME programs for all the doctors and medical students. So these credit points will be very valuable for you to renew your license and in different kind of healthcare related things. So, and we have knowledge session where you will be able to see all the latest news related to healthcare and medical field. So you will be able to be on track related to all the updates in medical industry. Apart of that, we have medval blogs. As you can see, we have different kind of blogs over here. And I request Shefali ma'am, if you can write a blog and you can post as we were planning for it. So once it is ready, we can do go for it and you can post the things on any topic, whatever you feel like to. And apart of
Definitely.
that, we have medical communities, people who wanted to see connect with different kind of medical network in different specialities. Please do, you're welcome to MedWorld Expo platform, and you can able to create your own communities, or you can able to join different communities. And we have journals and magazines where you can browse different kind of healthcare and medical journals, and even you will be able to republish your journals or magazines if you have any. And we have career advancement program, people who are graduated or post graduated. If you're looking for like pursuing abroad studies, right from the application status, we will be taking care completely, and we will be guiding you the pathway to reach your milestones. And we have job opportunity platform. If you can see, we have n number of like job openings in different kind of healthcare organizations. So if you're looking for any kind of job searching, so our platform is the right option for you to find out, because we are only into healthcare. So if you see other kind of job platforms, it is related to all the specialities, not only healthcare. So you'll be able to see in IT sector and everything. But if you come into MedWorld, it is specialized for complete healthcare. So it will help you to find the relevant job, and this is a place where employer can also find the right people in right place. So I wish people who are looking for jobs, people who are looking to post a blog, people who are looking for any attending the webinars or CME programs, so MedWorld is the right choice for you. And whoever haven't registered to MedWorld Expo, please do register www.medworldexpo.com. You will directly able to see login over there or register. If you haven't registered, please do register. And that's all about MedWorld Expo. Thank you so much, ma'am. Before I close the session, do you like to say any closing statement, ma'am?
Yeah, I would like to say that besides the lecture, the organization by MedWorld has been very good. It is
Thank
not something they've told me to speak, but being a speaker for the first time, maybe it was a very smooth process, and they're very responsible for what all they want in the lecture and how they want to organize it. So, if any one of you wants to attend more lectures, you should definitely register. And if you want to connect with me, you can do so on the WhatsApp group, or even on Instagram. Feel free to do so. Thank you.
Thank you so much, ma'am. I hope you'll have a very good day. Thank you so much for your time. And thank you all the participants who are being here till from last 1 hour. Thank you so much for being active participants.
Thank you all. Thank you.
Thank you. Have a good day, everyone.
Thank you.